Good afternoon, everyone. It is 2 o'clock, but we still have several more people who need to join. If you are a committee member, if you would please put your name in the chat so that way we can capture it for our meeting minutes. If you are a committee member who's on the phone, if you would unmute yourself and let us know that you are here. We should be starting here in the next couple of minutes. Thank you.
Hey, Sharon, this is Kim Danzy. I'm here on the call. I just had to call in instead of be on the Google Meet.
Well, great. Thank you so much. Yeah, thank you, Kim, so much. Thanks for letting us know you're on the call. And again, for those of you who have just joined, we should be starting here in just a few moments. If you are a committee member, if you would put your name in the chat and let us know that you are here. And Michael, just give me one more minute to tally up for a quorum.
All right.
We're super close. Yep. Okay, Michael, you can go ahead and start. We do have a quorum.
All right, very good. Thank you, Sharon. I'd like to welcome everyone to our March MAC meeting. We had our informal update in February, but we had our last formal MAC meeting back in January. So we do have our meeting minutes from January to approve, and those were sent out to everyone prior to the meeting a few days ago. So if you've had a chance to review those and don't have any questions, then I will entertain a motion to approve, or if there are questions, if you would bring them up so we can get those addressed, we can do that as well. Nobody's feeling inspired to make a motion to approve the minutes.
Motion to approve the minutes from January.
Okay, thank you, Rachel. Do we have a second on that?
Second, this is Kim Danzy.
All right, thank you, Kim. And since we're on a virtual or video conference format, it's difficult to read votes. We will proceed with the assumption that all members are in favor of approving the minutes unless someone votes no and tells us that. So any no votes on approving the meeting minutes? Okay, thank you. So with that, we will consider our January meeting minutes approved. as they were distributed. And next, we would like to welcome a new committee member, Colleen Kenny. Did I get that right, Colleen?
Colleen, just it's a little
Colleen.
more phonetic than you think, but
All
just
right.
yes, thank you so much. I appreciate it.
Great. We would like to welcome you. And do you want to take just a few minutes to introduce yourself to the other members of the MAC? So we have a minute to get to know you a little better as we'll be working together in the future.
Oh, shoot. Yeah. I don't know. I don't know what information you'd like about me. Again, it's Colleen Kenny. I am a parent consultant at the Utah Parent Center for the Utah Family Voices Project. I am the parent of a almost 25-year-old that is in services on Medicaid. She has been for a while. She has some genetic conditions that require her to receive quite a bit of medical services. And that's put me here in this world. I have participated in a lot of advocacy for about 20 years in that capacity. I appreciate this opportunity and look forward to getting to know everybody. Thanks.
Great. Thank you. We appreciate knowing that and hearing about your perspective. That'll be helpful as we deliberate on different topics, and always appreciate the experiences of those who are having children or personally receiving services through the system so they can offer perspective and insight. So welcome, and we'll look forward to working with you, Colleen. Thank you. All right. And then we'd also like to notice the committee that today Christy Grennan is sitting in for Brian Monson, who's unable to be part of our proceedings. So first item we have on our agenda, we have Laura Belgique, who will be giving us a background on the 1115 waiver amendments and an opportunity for public comment on the proposed policy changes. So Laura, if you want to proceed, thank you.
Great, thanks, Michael. So we have another 1115 waiver amendment request that I will be presenting today. This amendment will be submitted to CMS by April 1st. So as usual, this forum is an opportunity for you to ask questions and provide comments on the amendment. Before I begin, I know it's been a while since I've given a description of what the 1115 waiver is. And considering there are some new members, and so for those of you who may not know, or as a reminder, I'll just quickly mention that Section 1115 of the Social Security Act gives CMS the authority to approve experimental, pilot, or demonstration projects that are likely to assist in promoting the objectives of Medicaid. So it gives states additional flexibility to design and improve our programs. And most of the amendments come out of legislation. So the process is after we submit our amendments, CMS then reviews and gives us a yes or a no on our requests. Sometimes a yes with changes. And that review process is typically quite lengthy. And one of the requirements when submitting an amendment is to hold 2 public hearings where the public can again give input. And one of the hearings is held during this meeting where both the committee and the public can provide input and comments. So I will go ahead and read the overview, which you should all have on this current amendment request. And the entire amendment is available on the 1115 waiver website, which is listed at the bottom of the summary document. This is a positive change and is specific to increasing the reimbursement amount for children enrolled in Utah's Premium Partnership, or UP. So I will now present the overview. And as I mentioned, this amendment request seeks authority from CMS to allow the state to increase the maximum reimbursement amount for children enrolled in Utah's Premium Partnership. The amount would change from $120 per enrollee per month to an amount set by the state through our administrative rulemaking process and within the CHIP allotment limits. The UP program helps individuals pay for their health insurance premiums so they may afford their employer or COBRA health plan. And for the first fiscal year of implementation, the maximum reimbursement amount will increase to $180 per enrollee per month. As far as eligibility, individuals must meet the criteria for the following demonstration populations as currently approved under the state's 1115 demonstration to be eligible to receive premium reimbursement. Current eligible CHIP children are children up to age 19 with family income up to and including 200% of the federal poverty limit, who would meet the definition of a targeted low-income child. These children are eligible for CHIP, but the children's parents have elected to receive premium subsidies for the employer's share of the cost of employer-sponsored insurance, or ESI, instead of receiving coverage through CHIP. Demonstration population 6 is children up to age 19 with family income up to and including 200% of the federal poverty limit, who would meet the definition of a targeted low-income child. Demonstration population 6 is subdivided into 2 groups, the first being COBRA eligible children. And this is a child that meets the definition of a targeted low-income child who is eligible and able to enroll in COBRA continuation coverage based on any qualifying event. These children are eligible for CHIP, but the child's parents have elected to receive premium subsidies for the employee's share of the cost of COBRA continuation of coverage instead of receiving coverage through CHIP. And then second is COBRA continuation children. And this is a child that meets the definition of a targeted low-income child except for receipt of continuation coverage in accordance with the Consolidated Omnibus Budget Reconciliation Act of 1995, or COBRA, and who elect to receive such premium subsidies. And Sharon, if you want to scroll down, I'll just go on to the second page, which is benefits. If approved under this demonstration, qualified members will be eligible to receive the following services: assistance in paying the employees, individuals, or families' share of the monthly premium cost of qualifying insurance plans. The maximum premium assistance amount must not exceed the individual share of the premium and may not exceed the amount as will be stated in the state administrative rule. And again, the maximum medical monthly premium amount at the time of implementation of this amendment will be $180 per eligible child. The second is individuals eligible under this demonstration will have cost sharing requirements, including the out-of-pocket maximum as set by their qualified ESI plan. And dental benefits for children will be offered through 2 paths. If the health benefit package is available to a child through qualified premium subsidies, coverage includes dental benefits. The child's premium subsidies will be approximately equivalent to the per child per month cost under Title 21 state plan dental costs. However, if a child does not receive dental benefits through the qualified premium subsidy plan, the child will receive dental coverage through CHIP. Our proposed demonstration timeframe is that the state intends to implement the premium increase at the beginning of the first month after approval. And we do expect approximately 302 individuals to be eligible per year if the amendment is approved. And as I mentioned, the full amendment and other 1115 waiver documents are available on the website listed. And I will now open it up for public comment.
If we don't have any other public comments, I have a question. Laura, in terms of the maximum amount, the $180 per enrollee per month, I'm just curious, of those who are enrolled in the program currently, how many have premium obligations for the employee above 180 degrees? Or in another way to frame the question, how adequate do we think the $180 is at covering the employee's share of the premium?
I probably will defer that question to perhaps Brian or Jeff. You have input.
It's a good question, Michael. I do not have the answer at hand. We would only be able to say how many people are getting the maximum contribution right now. We don't have data at our fingertips of like what our contribution would be if we had to pay more. But we settled on the $180 figure based on consultation with legislative partners. So it was slightly arbitrary, but yeah, we don't know the number of people that may have fees even in excess of $180. I wouldn't be able to tell you.
Okay, yeah, I just think that might be a helpful piece of information in terms of the adequacy. Raising it, of course, makes sense. I'm just curious what the opportunity might be for individuals if we had a little insight into how much of the employee share would actually be covered with the $180 limit and how many people we might be missing if it is limited there but could go higher. But recognizing there are appropriation limits, I was just kind of curious on that. Okay, any other comments on this waiver amendment? If something comes to you, we'll still keep the public comment open throughout the duration of the meeting. And at the end of the meeting, we'll circle back. And if you have additional thoughts or comments you would like to make at that time, then we'll provide another opportunity later in the meeting just to make sure you have adequate time to think through this and provide comments. So with that, thank you, Laura. We appreciate the document and the background. Oh, okay, Brian.
Sorry, just one last thing to button up that subject, but we have about 110 members each month who receive the maximum contribution right now. So that's
which 120, right?
Yes.
Okay.
Yep.
Great. All right. That's helpful information. Thank you for getting that and sharing it with us. Next, we'll move on to the renewal of the 2 HCBS waivers. So Joseph, if we can have you make your presentation next. Thank you.
Thank you, Michael, and to all the committee members. I'm Joseph Ambernack, the Director of the Office of Long-Term Services and Supports. As Michael mentioned, we have 2 of our home and community-based services waivers that are set to expire, and we're seeking, or will be seeking, authority to renew those programs. Maybe a little bit of background as well, as Laura supplied. The term waiver ends up kind of permeating the Medicaid program a little bit. The 19C authority within the Social Security Act helps supply supplementary services to an individual's Medicaid benefit to enable them to live in home and community-based settings as opposed to the facility-based equivalent. So in our programs, we're often using a comparative of a skilled nursing facility or an intermediate care facility. And these programs are intended to supply supportive services that help avoid institutionalization or that need for facility-based care. The 2 programs, as I mentioned, are set to expire later this year. The tech waiver is set to expire on June 30th, and the medically complex children's waiver on September 30th, where we're bumping up the renewal of the medically complex children's waiver to try and better align with the state fiscal year. It helps with a lot of our financial reporting and projections. Not a lot of substantive changes, and we'll go through those in just a moment. But with these 2 waiver programs, they are operated internally by the Division of Integrated Healthcare within the office that I help oversee. And we are engaging in a lot of terminology adjustments, as well as incorporating some pieces from the public health emergency. The drafting process thus far and background for information on that side. We did hold a handful of work group meetings. I believe there were 2 sessions in January of this year where we went over the waiver implementation plans, which is effectively our contract with CMS as to how the programs will operate. We went through those in pretty significant detail through each of the appendices. For those who have gone through our implementation plans, they're about 150 to 200 pages long typically. A lot of very dry reading, but we were able to target a lot of the substantive areas surrounding service provision, person-centered planning, level of care determinations. And we got a lot of great feedback from providers, family advocates, and other advocacy groups as well. They helped form the current draft that has been completed, that has been provided for public comment. So part of our public input processes, again, in addition to the work group, we're sharing information here with you today. And I believe we sent out an email either at the tail end of February or early March, trying to share this in advance as our public comment period is limited to about 30 days. We also met with the Indian Health Advisory Board and the tribes earlier this month as well. I apologize for the typo. It should read March of 23 versus June 22. We'll make that adjustment. And then part of this will be the review of the comments received during this 30-day period for any additional changes that we might like to incorporate or are able to incorporate in the final submission to CMS. We'll be doing that at the end of March, allowing CMS their standard 90-day timeframe to review, and hopefully we'll have the waivers both effective for July 1st of this year. So a little bit of the changes for the medically complex children's waiver. We added some additional provider types for the purpose of respite delivery. There was a recent licensing change for pediatric respite facilities where we felt very strongly that they could meet the health and safety needs of the children in the program. And we also included some additional information surrounding reimbursement that is taking place under the American Rescue Plan Act, or the ARPA plan. This just outlines that information with CMS. It reinforces the reimbursement process that we've already been using to provide quarterly supplemental payments to providers based on their Medicaid revenue in the prior quarter. So again, just reinforcing that language and including it where our current authority under our Appendix K, that is with CMS, is set to expire with the public health emergency, or is tied to that date. With the technology dependent waiver, we made some corrections to a lot of the organizational units, as many of them reflected when the Children with Special Healthcare Needs group managed the program. So we were correcting a number of those pieces, as well as a lot of the DHHS terminology since the merger. We also added caregiver compensation as a permanent flexibility for any hours that are authorized but may be displaced by inadequate staffing for our nursing agencies, or possibly at the discretion of the family, just allowing them that option in their care delivery. Likewise, we also included the same pediatric respite provisions and added some language around that. And then the same ARPA provisions that we just talked about for the medically complex children's waiver will also be reflected here. Throughout the document, there were typo terminology corrections, but those are the substantive changes that are included there. We also, under the tech waiver, we have a service called Family Support Services, where it's essentially a little bit of grief counseling and preparation for families understanding the mortality of their children. We found a lot of benefit authorizing that service via telehealth during the public health emergency, and has become a very popular method for that service delivery and receipt, where it can be very difficult for our LCSWs to get out to provide that service. And I think we will be looking at making that adjustment as well. Just wanted to call that out too. So we are taking public comment through March 26th. And again, kind of taking that period between the 27th and 31st to finalize our submissions. You're welcome to send any of your comments. You can send them directly to myself. I think at the bottom of the document as well, there are some information for Susan Gunn, who is the program manager for both waivers. Our website also has a public comment form where you are able to send, and we'll certainly take any feedback or comments that you might have today as well. Yeah, if I can answer any questions now or share any additional information, please let me know, but appreciate the opportunity to come and speak with you today.
Thank you, Joseph. Do we have anyone who has any comments, questions, or statement they'd like to make on the renewal of those two waivers? Okay, similarly, if you have additional thoughts come to you during the meeting, we'll ask for an additional time to have you provide questions or comments if you have something come to you during the rest of the meeting. So thanks, Joseph. And all right, or as Stephanie's considering, reading through the document and providing comments to the website or email address as laid out in the document. All right, Joseph, thank you for being with us and making that presentation. Next, we have Jennifer Strohecker and Eric Grant on updates from the recently completed legislative general session. So we'll ask you to go ahead now, please.
Certainly, thanks. So Jen will be on shortly. So I'm going to start with the funding pieces and just do a very high level of what each of these funding items were, and she'll get into a much more detail when she's able to join us. So if you'll bear with me, it's kind of, I know it's a little unusual to talk about the funding first, but unfortunately, that's the reality we're faced with today. So can you see my screen okay?
Yes, it is displayed. Thank you.
Great, wonderful. Okay. Let's see now if I can make the slides advance. Here we go. So first off, we're going to talk about the supplemental appropriations for state fiscal year 2023, which is the year that will end this June. The first thing we have up is Medicaid consensus. We've talked about this several times in the MAC. This is the process where we meet with the governor's office and the legislative fiscal analyst. We pool our resources to make projections on what eligibility and enrollment is going to look like for the Medicaid program. And then based on that, we adjust the funding appropriately. We also account for one-time occurrences such as the continuation of the public health emergency. And then also in this case, we also had to account for the fact that they decoupled the increased Medicaid match or FMAP that we were receiving from the federal government with the end of the public health emergency and have kind of slowly wound that down. So we will receive a reduced amount each quarter through December 31st of 2023. So in order to adjust our funding for that, we had to make some adjustments within the Medicaid consensus process. So right here, this is the funding we're showing for state fiscal year 2023. And as you can see, the numbers in parentheses are negative numbers. So we will be giving back approximately $52 million in general fund. We will also be giving back authority to the expansion fund. With the expansion fund, we have the authority to spend whatever we need to cover those people. So it's kind of, we're giving back the authority, but not necessarily direct funds there. Federal funds function fairly similar to the expansion fund where it's authority. Here we're getting an additional $140 million in authority, and this reflects the extension of the public health emergency from the last time we did a consensus meeting. So any questions on Medicaid consensus? Am I frozen? Sorry, everybody's just very still.
No,
Okay.
You're doing great.
Our internet connection in the building's a little iffy. So sometimes I worry that, okay, did I freeze? And everybody's just, everybody was very still. So.
Okay.
Okay.
That's always good confirmation to make. Thank you.
Yeah, so if I do freeze, I'll try to keep checking in. Next up, we had equal rate for Medicaid reimbursement for autism. You'll see this one again in the 2024 funding, but for 2023, you can see they gave us an additional $1 million in general fund and $2.8 million in federal funds for this particular item. And basically, the attempt on this one, bring up a little bit of notes here. Was to increase reimbursement for applied behavioral analysis providers. And so this was trying to equalize that across all the programs that utilize these services. All right. Okay, so now we'll get into the funding for state fiscal year 2024, which is the year that begins July 1st. So first off here, we have Medicaid consensus. And as you can see, we have, for most of these 2024 items, we'll have a one-time and an ongoing funding line item or funding item on this document. The idea behind this is in the first year, because of that unwinding of that expanded federal match, you'll see some numbers up in the top in the one time that are making adjustments for those reductions in the FMAP as they happen. And then the bottom line of ongoing funding is this is what we're looking at on an ongoing basis. So as you can see, because of the end of the public health emergency and the overall unwinding, we're seeing a reduction overall in ongoing funding through Medicaid consensus for the Medicaid program. Next, we have Senate Bill 19, which was Medicaid dental waiver amendments. This basically allowed coverage for dental benefits for expansion adults, and these services will be provided by the University of Utah School of Dentistry. And so you can see there's some adjustments one time, like I mentioned earlier, but on an ongoing basis, we're receiving just under $1 million general fund and 1.9 million federal funds to provide these services. Next, we have House Bill 290 regarding the medically complex children's waiver. This is going to add about 190 slots to the waiver, which will increase the capacity of children that can be served on that waiver. As you can see, we're not anticipating this to start within state fiscal year 2024. That's why you can see the amounts almost perfectly match that we will have one-time funding, which reduces at the full amount, but then the ongoing funding. So we anticipate these services will start July 1st of 2024. Next, we have Senate Bill 204, which is autism coverage amendments. This is basically to cover autism services for adults. We're anticipating, and I apologize, I didn't have the total funds filled out on this one, I apologize. But as you can see, with 3 million general fund and 6 million federal funds, we're anticipating a total fund expenditures of around $9 million. Next, we have Senate Bill 133, which is modifications to Medicaid coverage. This is to cover contraceptives and family planning services for individuals up to 185% of the federal poverty level. Also will provide 12 months continuous coverage to women after the end of their pregnancy. We're anticipating a little bit of dedicated credits, which these are funds that come into the department to use that can be used as non-federal share, along with the general fund of about 2.9 million and federal funds of 6.9 for a total of $10 million. Next, we have Senate Bill 126, which is hospital assessment amendments. With this one, it's basically is an assessment to hospitals with a quality component that hospitals have to achieve, which will result in payments to hospitals. And as you can see, we're anticipating the assessment to be increased by about 57 million, an additional 221 million in federal funds for total funds of $278 million. Next, we have Senate Bill 217, CHIP coverage. This will expand CHIP coverage to children under 19 years of age who are qualified non-citizens or lawfully present children. Now, as you can see, we received funding from a new, I believe it's an expendable revenue account called the Alternate Eligibility Fund, and we'll receive funding of $4.5 million. Next, we have Senate Bill 2. And this was an item in Senate Bill 2, item 104, which is Medicaid annual WellCare visits for adults. This will cover physicals and just general well checks for adults. As you can see, we're anticipating 201,000 of general fund, 45,500 expansion funds, and 813,400 from federal funds for a total of just over $1 million. Next, we have House Bill 315, recreational therapy and Medicaid coverage amendments. This covers services by licensed recreational therapists in certain facilities. We're anticipating we've been given authority and appropriations of expendable receipts of 1.2 million, 60,000 with expansion funds combined with 2.9 million in federal funds for a total of 4.1 million. Next, we have Senate Bill 3, which is an increase to home and community-based service waiver rates. We were appropriated just over $500,000 in general fund and $1.6 million in federal funds for a grand total of $2.1 million. Next, we have an increase to air ambulance rates. Again, this was an appropriation to increase rates for both fixed wing and rotary wing aircraft. We received $1.7 million general fund and $7.4 million federal funds for a total of $9.1 million. Next, we have an increase for acute care and continuous PDN care rates, which these are rates, PDN meaning private duty nursing. We received an appropriation of $1.5 million general fund and $2.9 million federal funds for a total of $4.4 million. Next, we have the New Choices waiver rate increase. We received a general fund appropriation of just under $2 million general fund and $3.7 million federal funds for a total of $5.6 million. Next, we have medically assisted treatment administration. Sorry, I got to make sure my sheets are lined up. This is an increase in the administration and dispensing fee for clinic-based methadone treatments. We received $130,000 general fund, $59,100 expansion funds, $960,000 federal funds for a total of $1.1 million. Next, we have Senate Bill 237, dental hygienist amendments. This was more policy related, and we did not receive any funding for this legislation. Next, we have nursing home rate add-on for wages. We received $5 million general fund appropriation with federal funds of $9.7 million for a total of $14.7 million. Next, we have equal Medicaid reimbursement for autism. We received I believe this is the one that was in the one time from 23. We received an appropriation of $4.5 million general fund ongoing and $12.4 million federal funds for a total of $17 million. Now, these following items were appropriated to the Office of Substance Use and Mental Health, who are technically in our same line item, but we still are working on becoming a combined department. And so our financing groups are still somewhat separated, but we are working toward combining that. So they had items of community mental health Medicaid rate increase. As you can see, they're ongoing about $3 million general fund and $800,000 federal funds in state fiscal year 24, and a one-time give back of general fund in state fiscal year 23. We had House Bill 248, mental health service for adults, which was $1 million general fund, one time in state fiscal year 24. We had a social detox rate increase, which was $411,000 from the Medicaid expansion fund, one time in 23, and then $411,000 from the Medicaid expansion fund ongoing in state fiscal year 24. And finally, we have behavioral health prescription digital therapeutic pilot, $300,000 from the opioid litigation settlement fund, one time in state fiscal year 24. Any questions I could answer on any of these items? As there doesn't appear to be any, I know that Jen is now available and on the call, and I think she has a presentation to walk through some of these items in a little more detail rather than just the very dull and dry funding as I went through. So thank you very much.
Thanks, Eric.
Okay, thank you, Eric. And Eric gave you an overview of some of the funding and really covered some of the language that we have outlined here for your review. But I'd like to just give a little bit extra detail around some of the highlighted legislative items that we wanted to call your attention to. So the first item is SB 19 for Medicaid dental waiver amendments. And as mentioned, this would expand our coverage for the adult dental service population. So currently not all adults qualify for dental services and are able to receive them. This would expand them to populations like the expansion adults and low-income parents. So for the majority of our population now on Medicaid, this would enable them to receive access to dental services. As Eric mentioned, this benefit is delivered through the University of Utah School of Dentistry and their associated provider network. And this is run as a fee-for-service benefit. So the prior authorizations and the policy and some of the payments run through the fee-for-service program, but it's operationalized through the University of Utah School of Dentistry. And we have a collaborative relationship with them to do this work. And it's been a great benefit as we've been able to work together with our existing populations and to now expand it here. I do have called out the authority by which this service is authorized. And we have this one as an 1115 waiver, and the defined date by which we will submit the waiver is January 1st, 2024. We have this defined as the earliest realistic implementation date. I will say for this waiver, we have already begun some of our drafting of it in order to amend our current waiver and include these other populations. So we're excited for this coverage. The next is for our medically complex children amendment. And today we're able to enroll 710 individuals into the medically complex children's waiver. This funding that we've been able to get through this legislative session would be able to expand that coverage to 190 additional children. So I'm going to touch a little bit later on this program and just give an update on where we are. But just to go through, this runs through a 1915C waiver. Joe touched on it earlier. But one of the portions of this is that we did have funding for this last year, where we were authorized additional number of individuals that we could serve. We were approved for that expansion this past fall from CMS. So I will give highlights to how that expansion of services and how that application process and those changes are going, but we're really excited. We know that 710 individuals, which is what we currently are able to serve, may not serve all the needs of the community. So having 190 extra slots for this program will be really exciting. Possibly earliest implementation we have is January 1st of 2023 for this is our target date. Next is autism coverage amendment. So today we do cover comprehensive services for autism and the treatment of autism for EPSIT, the EPSDT eligible population. So individuals enrolled in Medicaid up to 21 years of age. We do have some limited services to assist with autism supports in some of our waivers, but this funding specifically expanded the treatment services for autism services for autism spectrum disorder for adults. So we will see that the services that we have available for children, we intend, as we look at our policy, one of our intentions is to develop a like service that would also be available for adults. So we would, again, we're just beginning to look at this as we've looked at a legislative debrief. Some of the things that we've talked about is creating more of a uniform benefit of services across this population. On our initial review, we believe this is a state plan amendment, which allows us to have the authority to do this. And our target date for this would be July 1st, 2023. Next is the modifications to Medicaid coverage. This is SB 133. And like Eric mentioned, this would expand our coverage for contraceptives and family planning up to 185% of the FPL. And that would be done through our 1115 waiver. This bill legislation also included an extended eligibility component for individuals after they deliver. So today, we offer 60 days postpartum coverage for our population who gets a pregnancy benefit. What this would do is it would expand this coverage for 12 months of continuous coverage after a woman were to have a delivery or end a pregnancy. There is a nuance to this bill where there is some limiting language that is not aligned with the state plan amendment option that CMS has developed for 12 months continuous. But there is a fallback provision. So what we intend to do with this particular waiver submission is to submit according to the bill language, which would qualify as our 1115 waiver. And then pending CMS review and approval of that, we will implement that program. If CMS does not approve that waiver by a designated date, then we have a fallback option to apply for a state plan coverage for the 12 months continuous coverage for women. And both of these, as they are 1115 waivers, we have these also slated for drafting as well. So Laura's going to be busy. The next piece is our hospital assessment amendments, and Eric touched on this already, but this creates a hospital assessment that does include a new type of hospital assessment that also incorporates a quality withhold component. So we are working with the hospitals now on our initial steps of this legislation. The next item is SB 217, which is CHIP coverage. And this expands, it actually develops a new service to expand a CHIP coverage to children under 19 years of age who are qualified non-citizens or a lawfully present child. This is through state-only authority. And I believe, as Eric mentioned, we have $4.5 million to enroll children who meet these qualifications. We are able to enroll up to the point of using those funds. And then we are to create a waiting list at this point in time after the funding has been used. There is a not a work requirement, but there is an income eligibility piece that has to be submitted to DWS as part of this. And the waiting list will also be managed by the Department of Workforce Services when they're doing the enrollment and the eligibility. The next item is the annual well care visit. So this, again, opens up some specialized codes to provide initial as well as follow-up annual physicals for adults. And so we will open that coverage on July 1st of 2023. The next is community mental health Medicaid rate increase. And our legislation on this guided us to increase the rates for 5 mental health treatment codes. We have these codes identified here in the table, and this would give a 29.2% increase to these specific behavioral health codes, which we will implement on July 1st. House Bill 315 is recreational therapy Medicaid coverage amendments. This is authorized under our state plan and allows us to offer recreational therapy services given by a recreational therapist in specified settings. And so we're able to expand this type of service. It's available now in limited settings through our waivers, but this allows us to have more expansive coverage of recreational therapy in these designated facilities. The next are rate increases that Eric touched on, but I'll just mention here quickly just for us to be able to go through them, is the HCBS waiver rates increase, as well as increase in air ambulance rates. We are able to also increase the rates for both acute and continuous private duty nursing care by modifying our policy a little bit and changing some of the acuity grid that we use to evaluate coverage. This would allow us to update this acuity grid that is used to score requests. They come in, be able to allow us to provide a longer duration and perhaps greater intensity of services for individuals who need private duty nursing. Mentioned the new choice waiver rate increase for these facilities for assisted living and memory care facilities. We're able to increase our rates for methadone dispensing. Last year, there was an increase given last year. This gives additional funding to clinics who are administering methadone to reimburse them at a more competitive rate. There were some modifications that were put forth as far as the dental hygienist amendments. This modifies our policy just a little bit by allowing dental hygienists underneath their scope of practice to operate without a collaborative practice agreement in certain public health settings. And so it kind of broadens the scope within certain settings. A couple other additional rate increases for nursing home rate add-ons for the wages specifically. We see funding that has been given last year. We were able to increase our reimbursement for ABA providers, but we're able to get an additional amount of funding towards these specific rates to get them closer to parity to other behavioral health rates. So we're happy to have that rate increase that will go into effect on July 1st. And then HB 248 allows for the creation of an additional ACT team. And these are, I think there will be, I believe, an RFP that will be submitted to see where this will be located, but it definitely expands, allows funding for the expansion of these really critical services that are vital for behavioral health response. Next is social detox rate increase. As noted here, it goes from $89 a day to $175 per day. We'll get that in place by July 1st. And then last but not least of our highlighted items is this pilot for the use of a digital therapeutic. This is an FDA approved application that is downloaded on an individual's phone and used in the treatment of SUD. In addition to other services for substance use disorder, specifically for use in the Medicaid population. That completes just our summary of some of our highlighted bills and funding increases that we were able to get this year for the Medicaid program. I can stop and see if there are any questions about this now.
Okay, any questions? Okay, Stephanie.
Thank you. Thanks, Jen and Eric. My question is kind of, I'm just wondering, like, there's a lot of good things that got passed and that's exciting. I'm just wondering, like, is there a way to have like an annual like report in the MAC or conversation scheduled it annually for like when there are these like expanded opportunities or increased reimbursements for new service like rec therapy or the dental services? How are we tracking like how that is like trickling down to the members and like how it's increasing access or health? And I'm just wondering if there's something that's already being tracked in the department that just can be shared with us, or if that's something that we can talk about having that kind of conversation just so we can kind of understand all the impacts of the awesome change, like improvements.
I'll take a stab at this, Stephanie. I think what I hear you asking, and it's a very valid question, that when we have funding put forth, how does it impact current, like if it's a new service, what is the utilization of that service? Or if it's an increase in funding, does that change access or utilization of that service at all? Is that what you're asking for? Some metrics?
Yes, ma'am. That's correct.
Yeah, I mean, I don't know if Brian or Eric have other things to add, but I think we'd be happy to report on where there have been changes, perhaps in funding or even the opening of a new service code, for example, and where the utilization has been, like whether, pre versus post implementation, or if it's a new service, we could track utilization across, periods of time to see where it is being utilized and if it makes a difference, just to have access and also just the rate impact.
Yeah, it's a good question, Brian here. So each of our 1115 waivers does also require a evaluation plan, and we contract with an independent evaluator who does either experimental or in most cases quasi-experimental, just defining a separate group either in the past or a separate geographic region that would serve as a control group. And we do regularly take the findings from those evaluation plans to this group to present what we have found as we've implemented those 1115 waivers. This session brings 4 or 5 new 1115 waivers. So and we would follow that. But we do welcome suggestions and comments on what would be important things you'd like to see measured as we do implement these programs, because we are right now developing hypotheses of what we would expect to see or like to test as we implement.
Okay, thank you for those responses. Andrew?
Hi, Jen. Just a quick question, because I don't know that I've been able to find it in easily find it in any of the documentation coming out of the session. But do you have a sense of where the rate increases for HCVS services are going to go?
Yeah, thanks, Andrew, for the question. We are going to have a meeting next week with some of our industry partners to talk about that. And so we haven't yet had those discussions, but I know we are going to be engaging in those discussions in the near future.
I didn't see any direction from the legislature around it. Did you guys get any and I just missed it?
I don't think so. I think it
Okay.
was an appropriation, and I think there may be some interest in, we're going to have a discussion about it next week, Andrew. We can bring that back to the MAC at our future meeting once we have designated places where that will, where those increases will be applied. We can bring that back.
Great. Thanks for the information. I appreciate it.
You're welcome. Any other questions on legislative updates?
Just pointing out a note that Laura Belgique has put in the chat that the 11-15 quarterly and annual reports are available on the website and offer demonstration updates and enrollment information. And she's put a link there for those who are interested in that information following along. One comment I have is I think it would be helpful at some point in the next month or so as you're working through the appropriated amounts, if we could see what the actual percentage increase or dollar amount increase is on some of those rates, especially for groups who are interested in bringing some proposal forward for the public hearing for next budget cycle, if they can have a better sense of where they're currently at on reimbursement. And that might inform people in terms of adequacy of rates after some of the current appropriations and better inform them for future potential requests.
We will. Okay. We will follow up and bring that to a future meeting.
Okay, then let's move on now to the director's report, Jen.
Sure, thank you. And as you can tell, all this work, we feel very blessed. It will keep us busy, but we will bring updates as well, just to, as we bring policy up, as we work on this policy, we'll bring it forth to the MAC. So you have visibility into the work as it's being done. So a couple updates I'd like to share on our program. And the first I'm going to focus on, I'm hoping this is large enough. Let me increase the size of this font here, is our update on our PRISM system. So as you're aware, we are replacing our current MMIS and MMCS systems with a new system called PRISM, the Provider Reimbursement Information System for Medicaid, on April 3rd of 2023. So just not even 3 weeks away now. As an update to this work, it has been a many years effort to get to this point. And some of the work leading up to this, which we've shared, has incorporated significant work on behalf of our staff to prepare and ready ourselves, but also our providers with the right tools and resources and awareness of the number of changes that are going to occur when our PRISM system goes live. I have a few bullets here that I'd like to just emphasize here, and I'll just highlight this area, is that we have on a daily basis numerous live trainings for providers to engage in. One of our greatest desires is that providers are aware of the changes and that they are ready for what will happen on April 3rd. Our staff conducts live training. We also tape those live trainings and put them on our website. Additionally, we have on-demand training materials as well. I will include our hyperlink to our PRISM training resources in the chat in just a moment. I do have it on this document so that you can access those and look at what we have available. If there is a training that you'd like to have or questions, we would be happy to have you request a live training and receive whatever tools and resources you need prior to our go live date. So just wanted to emphasize that. In preparation for our go live of our PRISM system on April 3rd, we have frozen our current legacy system. Most parts of our system are frozen now. And they were actually frozen as of Monday, March 13th. This means that claims processing, as well as many of the usual features that our system supports, are frozen so that the data can be taken out of our legacy system and moved into our new PRISM system. We do still have active eligibility, so that is still visible through the eligibility lookup tool. Pharmacy claims can still process for members who need them. And we have workaround procedures in place for prior authorization and also our waiver support services that we have. So in some places where our system is frozen, we've created workaround methods to support ongoing operations. In this freeze document, which again I will include in the chat here in just a moment, it is an FAQ for providers to really support what changes are in place right now during this freeze time. And so I will make sure that there is visibility to that so you can access that. I mentioned our go live date for our system is on April 3rd, and we are preparing our staffing to be ready for these changes. We are going to have just over a third of our staff here in the office. Most of our staff works full-time remote right now, and we will be bringing in about a third of our staff to support our go live needs. And the remainder of staff will be able to do their work from home. I wanted to call out that we recognize that a system change is going to have an impact on our customer service call volumes, and we anticipate that there may be a higher volume than what we experience today. We have extended our hours of service for our customer service lines, and I don't have it listed here. It will be 7 a.m. to 7 p.m. on Monday through Friday, April 3rd through the 21st. We are developing a comprehensive communication strategy to address concerns as they come in and work them up and provide you with responses, or if there are any sort of system defects that we need to address quickly. We are all hands on deck to work and support what this means for our Medicaid providers and our Medicaid members. And so just know that we will be having a very large change as our system goes live. We have extra hours of operation to support that need, and we will have all of our staff focused on this work during that time. Another piece I wanted to call out that hadn't been covered in prior Medicaid information bulletins that do detail many of the changes that are happening during the PRISM implementation and with our new PRISM system. And this is changes to our coverage and reimbursement lookup tool. And rather than read all of this, I will just highlight and say that our coverage and reimbursement lookup tool today is a very useful tool that providers, as well as even our own Medicaid staff and others, use as a way to look up some policy or coverage and be able to understand what is covered and how it's covered and at what rate it is covered. On April 3rd, because we are launching our new system, we will also be planning to launch a new coverage and reimbursement lookup tool that is built to align with the methodology that our new PRISM system uses. So what our plan is to continue to use our current coverage and reimbursement lookup tool and have that available to our provider community throughout our go live phase. However, the data in our current coverage and reimbursement lookup tool will be frozen as of March 13th. So that, I hope that's right, Eric. Yes, March 13th. So that any of our policy or the code coverage and the claims information that is needed for any date and time prior to March 13th can be looked up using our current coverage and reimbursement lookup tool. In order to support our new PRISM functionality and the way that we use some logic around provider type specifications, as well as some of our new language around code coverage and that type of thing, we have a new coverage and reimbursement lookup tool that is being built right now. That tool will go live just a few weeks after our PRISM system goes live. We have a data warehouse that is being built that will go live mid-April, mid to late April, and our new coverage and reimbursement tool that aligns with our PRISM programming and our PRISM coverage and any policy from March 13th forward will use that new coverage lookup tool. So this will be called out on our website. We will have views for both present with clearly defined language around timeframes and some of the disclaimers around the use of both of these tools. But we wanted to support and understand that knowing that timely filing allows our providers to bill for services back in time, that this would allow a look back into our coverage back in time for our old coverage and reimbursement and lookup tool. But we also have a new tool that will be used for our new programming in our PRISM system. And Eric, you may want to add any details that I didn't cover.
Sure, just a little bit of clarity. So understanding that providers do have 12 months to bill, but anything after March 10th will actually be processed with the new PRISM logic. So it will be kind of subject to that new tool. Now, just one other point of clarity, no rates were changed as a result of PRISM going live. The biggest change is just how that tool interacts. We typically and historically have used provider type, where you would go in and enter your provider type to look up a code to figure out if coverage was available. With PRISM, they have a new concept called a PAC code, or a provider allowable code, which is almost a one-to-one analogy with our legacy provider type. There are a few minor differences where the PAC code can get a little more specific than our legacy provider types could. So we actually view this as an improvement, and it will be better in the long run. But for the most part, the PAC code will be very similar and analogous to the provider type that was used in legacy. So just understanding that it's based on the date that the claim is adjudicated. So anything that's adjudicated in our system after March 10th, after the freeze, will be in the PRISM system, and that new tool will be the appropriate place to look it up.
Thank you, Eric. Are there any PRISM related questions that we can take right now before I move on to our next updates? Okay, thank you. I'm not going to include any points on unwinding the continuous eligibility requirement. I believe Jeff's presentation will cover updates on that. I do want to highlight two program updates. One is for our medically complex children's waiver, and our other is our housing related support services, just as an update to our enrollment and individuals who are utilizing services. So Stephanie, I'm hoping this actually fulfills one of the requests that you had around how services and utilization is changing. For our medically complex children's waiver, as you know, our waiver was approved by CMS to update our program to allow for more seats, and it actually created a waiting list for us to utilize for this program. Since October 1st, when we opened this service, we have received 286 new applications. So we've had hundreds of applications actually submitted since that time. And in fact, the great news is 186 of these applications have been accepted into the program. So we now have about 600 out of 710 available slots. 600 of those slots have been filled by individuals who can benefit from these services. So we're really excited for that. I did want to call out that while our projections will indicate that we believe we will fill up all these slots by midsummer, we are able to open additional slots to serve 900 up to 900 individuals with the funding we got from this legislative session. So just wanted to call that out. There has been a lot of activity in the medically complex children's waiver space, and wanted to let you know the good news about having now about 600 enrollees. Also wanted to touch on housing related support services. So this is a program that, again, this was a waiver service that was authorized by CMS and went into effect October 2022. And I have, by definition here, the housing related support services program provides housing related services and supports in the forms of tenancy support, this tenancy support, community transition, and supported living services to Medicaid members experiencing homelessness, food insecurity, transportation insecurity, interpersonal violence, and or trauma. What these mean specifically, if we have a hyperlink to our webpage that defines these services, but this is a really great program that addresses some social determinants for individuals who qualify. Supported living services provides a variety of coordinated services, which do not include room and board specifically, but they include mental health services, substance abuse services, independent living services, community and peer support, and crisis intervention. The aspects of tenancy support, which are really great and helpful for individuals who qualify for this, are they assist with tenant screening and housing assessment. So they really help people move through that housing application process and helping find the right setting for the individuals. We also help with people so that they have education and training on what some of their rights are as a tenant and what the landlord's rights are as well. We're aiming to help reduce evictions. And so there's training around this, as well as assistance with housing vouchers and subsidy recertifications. The last piece around community transitions is the piece that covers some security deposits to help pay for first and last month's rent. It also provides some financial support for individuals so that they can get their utilities set up and help arrange for utilities, as well as some basic necessities like household furnishings and some of the pieces like furniture and some just basic living supplies that individuals need who may qualify for these services. I'll take your question in just one second, but just to finish my update, so far it's been great. We've had 63 people qualified for this program already, and we have 3 enrolled providers. Our HRSS team is actively working with more providers in our community to get them enrolled as housing-related support services providers, and we have 4 additional providers that are looking to be added to our panel now. So just wanted to give an update on this, and I'll take whatever questions you have. And certainly, Joe, if there's any additional questions, Joseph and Brian are here on the line and can support as well.
So Stephanie had put a question in the chat about which providers are participating in this right now.
Yep, that's great. Thank you. Joseph, could you provide a response? And if not, we can certainly get back to you, Stephanie, with the names of those providers before the end of the meeting. But go ahead, Joe.
Yeah, absolutely. They are providers that have been involved in homelessness services for quite some time, as well as some new ones as well that have engaged in outreach to us. But entities like the Road Home Volunteers of America, Odyssey House, and Switch Point down in Washington County are among several of those entities. But as Jen mentioned, we're reaching out to others. It's a little bit of a precarious time with Medicaid enrollment right now with our PRISM freeze, but we're actively engaged with those entities as well.
Thanks, Joseph. Andrew.
Yeah, thanks, Jen. Ryan, it's the the session has happened since the last time we talked about this. So I don't remember if I asked you and you gave me the answer when we talked about it last or not. But I'm just curious if um if participants in the program are required to work with a participating provider, or if they can, if they are able to find a landlord who's willing to work with them and the program, if they can, if the program will work with any willing landlord or just these particular providers at the moment.
Go ahead, Joe.
Thanks, Jen. And largely the services provided through HRSS specifically, so the housing supports or the tenancy support, supported living, and then the community transition services. We do have qualifications that they need to meet the certified case manager requirement. So outside of Medicaid's general, any willing and qualified provider, there are some specific qualifications that they do need to meet in order to deliver service. So it wouldn't necessarily be accessible to individual landlords, although certainly we anticipate coordinating heavily as individuals find housing and are working through the sustaining housing that they may be a part of that equation as well, but not necessarily as a paid provider at this time.
Thanks, Joseph.
Thanks, Joseph. Any other questions for us at this time? Okay, great. Thank you very much.
Thank you, Jen. Okay, next, Jeff Nelson. We're going to have the eligibility and enrollment update.
Good afternoon, everybody. It's good to be with you and to talk a little bit about what's been going on. As you've already heard, nothing's happening in Medicaid this year. That's just not the true statement, right? We're going through a lot right now. In addition to everything you've just heard about, all the new things coming, we are also working on the unwinding, which started in our case in the state of Utah on March 1st. So I'd like to take you through some of the data, but I am going to share with you a report first that you can see the total number of cases that DWS will be going through and the number of individuals by that. It's a large number, and hopefully we'll share this with you quite quickly. We had hoped to get this information out to the MAC body earlier. We're sorry and apologize for not being able to do so. Our hope is in the future we'll get a little bit better at this and be able to get that information in advance of the meeting here. For today, this may be one of the highest numbers we ever see in the state of Utah. We'll see if that's true. 526,682 individuals on Medicaid in the month of February. Of course, that increased probably slightly as the end of the month approached, and our numbers somewhere around that figure. This chart is meant to show the amount of work that's in front of us. We have 526,682 people to look at to see if they qualify for Medicaid. It continue to qualify for Medicaid. The light blue is trying to show a little bit of a difference of those folks in that some of those folks we haven't talked to in some time. They've either not completed a renewal, or perhaps they have completed a renewal, but they were not, would not normally be eligible in the past. We were unable to close any cases or even transfer folks to CHIP or to the exchange. And so we've held those cases open. So that's what you're seeing there when you see the total Medicaid individuals at 526. And you see a number of 270,971 that are being held open. This does not mean that they're not eligible. It just simply means we haven't talked to them. We don't know what's going on. For that matter, the people in the purple, which include the people in the green there, we don't know about any of them until we look at their cases to see what's going on. So it is a little bit of work, as you can see, as we begin this Herculean effort. So as you've already heard, the continuous Medicaid enrollment requirement has ended officially. And that means that after the April 1st, we are able to move people to transition them to where they should be, which hopefully is the exchange or perhaps another Medicaid program or even the CHIP program. And certainly some will lose eligibility altogether that maybe are over income, et cetera. We did start and expect roughly every month there'll be about 29,000 cases. Cases, when I say cases, means households or families that are going to be looked at each and every month. And the first of those are started in the month of March. So DWS was notified which cases those were, and I'll show you what that looks like in a second. And they've started doing what's called an ex parte process. That means a review without the person involved. That really in the background means that they're opening up the case, taking a quick look with all the information that we have to see if they can simply renew the case for another 12 months and move on to the next case. When they can do so, they do that. And if not, they set that case to issue a paper review or an electronic review, depending on what the person has chosen. That pre-populated review then has to be filled out and returned. And about the time those are coming back, the next 29,000 families will be being looked at in this ex parte way. So this month is busy, next month is busier, and it will stay busier like that for the next 11 months. So it's a lot for DWS to take on. And I know Marissa's on here. We'll happily answer some questions about DWS and their process if you'd like. We thought it was also helpful to call out again that we do have an unwinding data dashboard with a link that you're seeing, I hope, on the screen. And I'll show you that actual data in just a moment. We did hear shortly after the continuous enrollment requirement was paired off from the public health emergency that the public health emergency itself will be ending on May 11th. And that has other implications to Medicaid, but it did not change this effort or when we began this effort with the unwinding of this particular law. We did send out notices as was promised, and all of those notices are placed online where you can see them. I'll show you those in just a moment as well. And you can pull up any of those in English and Spanish and share. We color coded those so you would know if someone says, hey, I had that yellow notice, you could say, oh, well, that was the CHIP notice. Let's take a look at that one together. Or light blue for spend down, and green was the generic notice for everybody. Green for go, if you will. We've added a lot of information to our unwinding webpage in addition to all of this, and are trying to maintain our status as one of the most transparent states. There is a tracker out there in the world. I'll flash that over here for just a second. I have not refreshed it today. You'll see that Ohio, Iowa and Ohio are the two in the darkest blue, meaning they're sharing the very, very most. Utah has shared the same documents, and we hope to turn dark blue here as well to be with those other states. Going back to our notice, we will put this on each of these updates as we go forward. This might be helpful for people to understand that there are no cases or no families that are going to be ending their benefits at the end of March. We are starting the process of looking at April reviews. That means we're starting early, March 1st, to look at April reviews, which really are about, does someone qualify in the month of May? So it's for May benefits. And we'll put that, and the next month in April 1st, we'll start looking at the May cases, which are for June benefits. So what that means is if someone's going to experience a closure, that's going to be at the end of April in the first case. And those cases that we start looking at on April 1st really don't close, if they do close, until May 31st. We'll continue putting those kind of data. I think that's helpful for you to see.
So in this particular case, Eric, yes, Jeff is frozen. That's probably because he's broadcasting from the Red Iguana, where he's not used to broadcasting from, but we will maybe have to get a reprisal of some of these details he's sharing with us that aren't being broadcast. But we do think, let me just ask Marissa, do you have any additional comments to add to what Jeff has presented?
No, I think Jeff has done a really good job covering the magnitude and the amount of work that's coming our way. As he has stated, as we start working on March's benefits for future months, the other element of workload that's going to be coming our way is folks that potentially end up losing benefits or losing eligibility for Medicaid will also start reapplying. So this initial month is very busy for us, but I think the compounding effect of reviews and new applications coming in will come to us sooner rather than later. In terms of workload, I think I can probably just add that if you're trying to put in perspective this number of reviews that we're doing on any given month, that roughly represents double the effort that we have seen in the previous months. So we really are trying to huddle together and support one another as we go through this workload. But the number of reviews simply is potentially double from what we see in any average month.
And how successful have you been as an organization in being able to hire enough workers to anticipate the workload? I know this has been a multi-year planning effort, but the labor market's tight, and I'm just kind of curious what other challenges you've been confronting there.
That's an excellent question. This is not just an issue in Utah. This has been a topic of conversations for many states, and I have been included in many meetings, as I would imagine many of the folks on the DHHS side have been part of many meetings to where we've kind of talked about our woes with being able to recruit and keep staff, specifically in eligibility. We have, for the past year and a half, maybe had a total of 2 months where we're not training staff to actually add to our roster. So every single day, for the most part in the last year, we have had a group of folks that is trying to be trained and starting to join us. Currently, we are fully staffed, stepping into this, and we have another group of 70 or about 65 folks that are currently being trained to join us in the next month or so. So it's been a struggle, but I think we've been managing it as good as can be expected. One of our strategies has been a lot of these entities that have had issues have not done things that we have done. For us, things that have helped us recruit folks is by allowing and expanding telework. Then on top of that, what we've also done is with that we have expanded rural hirings, where these jobs are still pretty lucrative. So that gives us an edge in terms of hiring.
Okay, great strategy. And good, I'm happy to hear that. You do have quite a lot of work ahead of you. I mean, when you put in perspective that for the last 3 years, you have hired people who've never done a review, and now all of a sudden you have all of this type of additional workload coming in. That's a lot, and we wish you the best and are very interested in how things proceed. So thank you for all your preparations, working with the Department of Health and Human Services and preparing for this, because that will be a very important amount of work. So you have our
best
wishes.
This has been a collaboration at a level we haven't really done before, simply because how long the planning has gone on. The year of planning that we have given this or more is really starting to pay dividends.
That's great. Thank you for that report. We appreciate it. Okay, I don't see that Jeff has come back on yet, so we will assume that he has been terminated from his internet service provider for non-payment of fees or some other cause which is unknown at this point, but very good timing as that happens to play out sometimes. All right, next.
Be a failure to tip, Michael. Sorry.
What's that?
As you indicated, if he was reporting from the Red Iguana, it might be failure to tip, and they pulled the plug on.
There you go. He lingered too long at his table and may not have given a sufficient tip. So we will ask him about all of these potential scenarios in our next report from him and have him set the record straight. Okay, next we have committee member updates. And one of the things I wanted to mention to the MAC and the public in general is that the Department of Health and Human Services has requested that we move up the public hearing from our historic June public hearing and then a July vote. That seems to be ending the process a little bit too far into their internal prioritization process. And they have requested that we move the public hearing up a month into our May MAC meeting, which would put it just 2 months away. And then we would have our vote in the June meeting. So we just want to start informing people that the public hearing, which normally would have been in June, will now be on May 18th. And we'll notice the public of that as best we can. But since this group of people is the group most likely to be interested and inform others about participating in the public hearing, we wanted to get that word out to the group and let you know about that. So any comments or concerns about moving the date up into May? Okay, if there are, and we can make some accommodations as part of the change, we would like to be able to do that, but just want to inform people as best we can to start preparing any of those presentations a month earlier than maybe what has been planned. Okay, other committee member updates that people would like to bring up to the MAC and discuss experiences, concerns with policy, procedures, interactions with providers. Okay, and then again, as this is the public hearing for the 1115 waiver amendment and the 2 HCBS waiver renewals, did anybody have any comments on those that they weren't able to make or didn't think about earlier in the meeting that they would like to make now? Okay. Well, if you do have additional thoughts, again, we refer you to the documents that were sent out in the meeting prior to the meeting to offer the public comment by a written submission. Colleen, you just came on camera. I'm curious if you want to make a comment.
No, thank you. Just ready.
Okay, very good. All right. Well, if nobody else has any business they would like to discuss or comments on those waivers, then we will go ahead and adjourn our meeting. Okay.
Thanks,
Thank
everyone.
you all for your participation. Bye.
Thanks, everyone.
Thanks, everybody.